Thank you very much, and I'm extremely grateful to Professor Azim and his team for their gracious invitation to be a part of this wonderful academic event. And the topic which have been given to me is the role of the FDG PET-CT in squamous cell carcinoma of head and neck. And regarding this presentation, I have no conflict of interest to declare. And in next 20 minutes, we'll be discussing how the PET-CT imaging is performed. And then definitely we'll go through its role in staging carcinoma of unknown primary, its role in assessment after the chemoradiation therapy, role in radiation planning, and also the follow-up and surveillance, as well as the recurrence in suspected patients. As we know that the head and neck is the 7th most common cancer globally, and 90% of the histopathology is usually the squamous cell carcinoma, and the 10% of the patient, they do have lymphoma, thyroid, and salivary tumors gland. The 5 years of overall survival is about 63%, which reduces to half once there is the nodal disease, even it is an occult kind of the metastasis. Therefore, the role of the imaging is very important and paramount, both morphological and hybrid imaging. The morphological imaging, which includes the contrast-enhanced CT and MRI, plays an important role in T-staging because of its higher spatial resolution. MRI, specifically because of its high soft tissue contrast, plays an important role in patients with nasopharyngeal, oropharyngeal, and oral cancer. And it is considered as a modality of choice for the diagnosis of perineural extension, marrow, and mandibular invasion, and certainly in patients with brain metastasis, where the FDG PET-CT has limited sensitivity due to the presence of the normal enhanced FDG uptake in brain cortex. While the contrast-enhanced CT plays an important role in T-staging of the laryngeal cancers, for bone cortical invasion and in small lung lesions which are less than 1 centimeter, and because of the partial volume effect, FDG PET-CT has limited sensitivity to detect. The FDG PET-CT based hybrid imaging plays an important role also in initial staging, but primarily in nodal and distant metastasis except brain and lung. It is considered as the modality of choice, as Dr. Farooqi has mentioned, that the carcinoma of unknown primary for the detection of primary tumor. Second primary tumor during the workup of the head and neck cancer is not uncommon, and it is seen in sizable portion of the patients. Then finally, the radiation planning and the recurrence. This slide briefly shows to the residents and the others who are not familiar with how the FDG PET-CT is performed. After 6 hours fasting, when the fasting blood glucose level is less than 200, intravenous injection of the FDG PET-CT is given, and then the patient is asked to stay in a calm and quiet room, and after at least 60 minutes of the uptake time, patient is scanned under a PET-CT scanner. From midbrain to mid-thigh, first the CT, followed by the PET images are acquired, and then these images are assessed visually for the qualitative assessment, and also we draw the region of interest over hypermetabolic areas, both primary and the metastatic lesion, for the semi-quantitative assessment and calculation of the standardized uptake value. So this is the brief summary how the FDG PET-CT is done. As we know that the FDG PET-CT has higher diagnostic accuracy for the detection of the primary tumor, more than 90%. But because of its limited spatial resolution, it is not considered as a modality of choice for T-staging because its correlation, anatomical relation with the neighboring structure is not as precise as it is seen on MRI and contrast enhancement, CT. The false negative findings for T-staging are not uncommon, especially for the small tumors and tumors which are lying in the pharyngeal lymphoid tissue. Similarly, the false positive findings could be due to the areas of the higher physiological uptake and in patients who are having a concomitant inflammatory process, because the basic limitation of the FDG is that it is sensitive, but it is non-specific. It is taken up by the neoplastic as well as the glucose-dependent inflammatory and infective processes as well. In dental artifact, where the mandibular invasion is an important question which is being asked by the surgeon, FDG PET-CT outperforms contrast enhanced CT with more than 90% sensitivity and specificity. This is an example of squamous cell carcinoma lymph node in right upper cervical region, and when we see the palatine tonsils, there is a symmetrical mild FDG uptake, but the biopsy revealed that there was a squamous cell carcinoma in right tonsil, so this is an example of the false negative finding. The nodal involvement, as we know, that is considered as the most important prognostic factor, and as a matter of fact, in any malignancy, in most of the malignancy, once the nodal disease is there, the disease is considered as stage 3. So it upstages the disease to stage 3, and it also predicts the nodal recurrence and the distant metastasis, and survival is reduced to 50%. And FDG PET-CT plays an important role and effectively outperforms the CT and MRI with sensitivity and specificity more than 85%. This is an example of a patient right-sided supraglottic tumor, hypermetabolic tumor in the right supraglottic region, and CT and MRI, they are showing concomitant hypermetabolic lymph nodes in right cervical region. But PET-CT showing an additional hypermetabolic lymph node in left side of the neck, which was consistent with metastatic lymph node, therefore it has upstaged the disease. In patients where the clinically neck is negative, it is an important question to answer whether the neck dissection should be performed or not. In this regard, American College of Radiology conducted a multi-institutional trial, that is the ECRIN 6685 trial, and in this trial 23 ACR affiliated institutes were recruited. 212 patients were included and having the T1, T2, T24 disease with C and NOT disease. And these patients underwent FDG PET-CT and the neck dissection. An interesting finding was that the negative predictive value of the visual analysis of the PET-CT was 87%, which increased to 94% using a cutoff SUV max of more than 1.8. And in this ECRIN 6685 trial, which was published in 2019, the surgical management was changed in a sizable number of the patients, that is 22%. As we know that the distant metastasis in head and neck cancer is not very uncommon at the time of the presentation, that is seen in about 2 to 18% of the cases. But once it is there, it is an indicator of the poor prognosis, and usually the radical treatment is avoided. The common sites of the distant metastasis are lung, liver, and bone, and the predictors of the distant metastasis are locally advanced nodal disease and also in patients with the recurrence. PET metabolic imaging predictors of the distant metastasis are higher SUV max over the primary tumor as well as the nodes, increased metabolic tumor volume, and the total lesion glycolysis. These are the three commonly used metabolic markers, and according to the various findings, the MTV and the total lesion glycolysis are the independent predictors for the disease progression and overall survival. Certain biological markers are considered to favor the better outcome, like the Epstein-Barr virus positive serology and human papillomavirus positive serology with a positive favorable outcome in patients with head and neck cancer. According to the NCCN guidelines, which was published 2.22 and 3.22, they recommend to use FDG PET-CT in locally advanced nodal disease and also in distant metastasis. And in this regard, when we see that there is, this is a case of the nasopharyngeal cancer, we can see that there is left-sided nasopharyngeal cancer with bulky hypermetabolic nodal disease predominantly on left side. But in addition to that, there is a hypermetabolic marrow deposit in C7 vertebrae, therefore it upstaged the disease to stage 4. This is another example, right tonsillar squamous cell carcinoma. The patient is having right tonsillar hypermetabolic lesion, bilateral hypermetabolic nodal disease, but on CT there is small hypodense area which is showing the abnormal metabolic activity, and the biopsy turned out to be squamous cell carcinoma metastasis. So again, this patient was stage 2, upstage to stage 4. The detection of the second primary malignancy in the workup of these patients is not uncommon, and the reported incidence is about 5 to 10%, and these lesions could be synchronous or metachronous. The primary sites of involvement are head and neck, lung, and esophagus, and commonly seen in smokers and also in patients with HPV negative serology. The metastatic squamous cell carcinoma of cervical lymph node of unknown primary, it is seen in 5 to 10% of patients. And as Professor Farooqi has mentioned that in such patients, usually the primary tumors are not detected on clinical examination, pen endoscopy, and also on the cross-sectional imaging. Therefore, the American Society of the Clinical Oncology Guidelines, which was published in 2020, they recommend to use the FDG PET-CT in SCC metastatic lymph node for the detection of the carcinoma of unknown primary. In one meta-analysis, in one study which was published in 2012, the pooled detection rate was 40% with a false positive finding in 9%, and the common sites of both false positive and false negative findings were the palatine tonsils and base of the tongue. Like in this patient, we see that there is a hypermetabolic lymph node and there is a hypermetabolic primary tumor which is lying in the nasopharynx. A therapy response assessment, accurate assessment after the chemoradiation therapy is very crucial, and the radiation oncologists and the treating oncologists, they are very enthusiastic to know about the response, especially after the 3 months' time. And the morphological imaging has limitation because after the surgery, radiation, and chemo, there is significant treatment-induced edema, loss of fat plane and scarring. Therefore, the sensitivity of these imaging modalities is reduced as far as the metabolic response assessment is concerned. However, the certain cytostatic agents which have also been introduced nowadays, they cause significantly, they cause reduction in the size in a gradual manner from 6 weeks to 6 months' time. Therefore, the precise assessment on the response assessment usually is delayed by if you use the CT and MRI, which is not possible for the precise management of the disease. Therefore, the NCCN guidelines recommends to use FDG PET-CT for precise assessment of to therapy after the CCR therapy with a negative predictive value of the 94 to 97% and positive predictive value of 75%. And the overall survival and disease-free survival is not compromised if you have a negative FDG PET-CT 3 to 6 months after the chemoradiation therapy. As a general consensus among the nuclear medicine fraternity, we usually use the criteria if there is the mild diffuse FDG uptake, we usually call it post-intervention inflammatory changes, but if it is an intense focal FDG uptake, we usually call them as residual disease. However, in this regard, the various professional societies, they have published various reporting guidelines, and one of them is the Hopkins 5-point scoring system. 5-point scoring system in which the hypermetabolic uptake over the primary tumor and metastatic lymph node is compared with the eye internal jugular vein uptake and the liver uptake. For score 1, where the focal uptake is less than internal jugular vein, it is considered as complete metabolic response, while for score 5, when there is a focal and intense uptake, it is usually considered as residual disease. Response assessment, American College of Radiology, they have also issued the NIRAD, that is the neck imaging reporting and data system, but the limitation with NIRAD is that there is no reference standard for FDG PET-CT uptake. Therefore, there is a significant poor inter-observer reproducibility, and as a result, most of the nuclear medicine fraternity, they do not use NIRAD category. What we use commonly, we use 3 metabolic parameters, these which are the semi-quantitative, that is the SUV max, metabolic tumor volume, and the total lesion glycolysis. If there is a more than 30% decrease between the baseline and the post-therapy, we usually conclude that this is a partial metabolic response. But if there is 20% increase from the baseline or appearance of a new lesion, generally it is called as metabolically progressive disease. But at this point, it is important to understand for everyone that accuracy of the metabolic response assessment on baseline and the follow-up depends upon the standardization of the imaging protocol. This is very important because if the baseline and the follow-up images are performed with the different imaging parameters, then the precision would always be compromised, because FDG uptake depends upon so many confounding factors, starting from the fasting blood glucose level to the calibration of the gamma PET-CT scanner. So it is very important, and this finding and this recommendation has been categorically stressed by the European Association of Nuclear Medicine guidelines in 2015, that standardization is very important when you are using the FDG PET-CT for precise metabolic response assessment. This is an example of hypermetabolic primary tumor in C oropharynx with bulky hypermetabolic nodal disease, and 3 months after the post-CRT, there is a complete normalization of abnormal metabolic uptake consistent with complete metabolic response. Another case of the C nasopharynx, we can see that there is hypermetabolic bulky disease predominantly on left side, but after chemotherapy, there is a significant reduction but not complete normalization. So this is a case of the partial metabolic response. This is a case of the right-sided tonsillar squamous cell carcinoma with primary disease, nodal disease on both sides of the neck, predominantly on right. And after the 6th chemotherapy, there is a significant reduction, but the uptake of the FDG is greater than the internal jugular vein. And 5 months down the line, there is a recurrence of the enhanced uptake over the nodal disease consistent with metabolically progressive or the active recurrence of the disease. This is a case of the post-CRT negative FDG PET-CT study, and it is a generally consensus that it essentially rules out the viable disease, and therefore in such cases no neck dissection is required. In this regard, one study was published in 2008 where they found that there is a metabolically non-avid hypodense lymph node, and in such patient they considered that it excludes the viable tumor with a specificity of the 89%, negative predictive value of the 97%, and these patients did not undergo neck dissection without compromising the overall survival. The FDG PET-CT has really entered into the radiation oncologist arena, and they are working together now because the FDG PET-CT helps them to select the patient, whether the patient is having a locally advanced or the metastatic disease, the plan should be curative or the palliative. And by using the FDG PET-CT, they can do a precise delineation of the gross tumor volume. And by using the dose painting technique, they can always escalate the dose to the hypermetabolic or hypoxic subvolumes of the tumor. Similarly, in the adoptive radiotherapy technique, the radiation oncologist can always decide to escalate or de-escalate the radiation dose during the phase of the therapy. This is an example of the delineation of the gross tumor volume by using the contrast enhanced CT and the FDG PET-CT. And here we can see that the PET-CT based gross tumor volume and the planning volume is significantly smaller, therefore avoiding the unjustified radiation exposure to the neck soft tissue. Cost-effective analysis in patients who have achieved a post-CRT negative FDG PET-CT 3 months after the chemoradiation therapy. The various randomized clinical trials have been conducted to compare the neck dissection versus no neck dissection in patients who have achieved a negative FDG PET-CT. And in this regard, the most famous clinical trial, which was published from United Kingdom in 2016, was a PET neck trial. And it was published in New England Journal of Medicine that PET-CT surveillance versus neck dissection in advanced head and neck cancer. And the findings were thrilling that there was no change in the quality of life in patients who did undergo for the neck dissection and without neck dissection, despite of having a negative FDG PET-CT. But the cost saving was $2,200 in those patients who did not undergo for neck dissection, despite of having a negative FDG PET-CT. So at this point, I would like to conclude the talk by these points that the FDG PET-CT is an effective imaging modality in the management of the head and neck cancer. And in patients with locally advanced disease, FDG PET-CT is considered as a standard of care. And based on the current evidence guidelines, it is considered as a better imaging modality for initial staging in nodal and metastatic disease. It is considered as modality of choice for the detection of the primary and carcinoma of a non-primary. It is playing a very important role in the arena of the radiation oncologist, and it is considered as a modality of choice for treatment response assessment, early treatment response assessment, especially 3 months after the completion of the chemo radiation therapy. And finally, the high negative predictive value of FDG, negative FDG PET-CT essentially rules out the possibility of the neck dissection and results in cost saving. But at this point, before terminating my talk, once again, I would like to reiterate the important finding and recommendation that standardized imaging and protocol is at most important when we are using the follow-up FDG PET-CT for metabolic response assessment. Thank you very much, ladies and gentlemen. I would like to conclude my talk. Thank you very much.